Okay. All right, guys, so before you come in for lab this week, I wanted to give you a quick rundown of what the WBC procedure looks like, because there's a lot of stuff that you won't have really done before in lab. It's not really hard necessarily, but it's hard to explain without having a visual to go along with it. So we are going to use this year these things called the leukocheck reservoirs. So inside this reservoir is ammonium oxalate, which acts as the diluent for this procedure, and the function of ammonium oxalate is to lyse all of the red blood cells that are in your suspension so that you can more easily view the white blood cells, and you can use this for platelet counts as well, even though we won't do that. The purpose behind lysing all of the red cells is because the red cells are the most numerous cells in your blood. And so you have lots and lots of red cells, and if you're trying to count only the least numerous cells, your white cells, it's really challenging to do that with all these red cells are sort of in the background and in your way. So ammonium oxalate is going to help you lyse your red cells so that they do not become an interfering factor and make your white cell count inaccurate. So in order to do the count, you're going to need a reservoir, and then you also need this pipette assembly. And you will need a tube of well-mixed EDTA blood. We will have that for you when you come into lab. The first thing that you want to do is leave your pipette assembly fully intact, but take the hard pointy end here and shove a hole through the top of that reservoir cap. You want to push evenly and consistently downward. You don't need a ton of pressure, but you need just a little bit. And so you do have to put a little bit of force in behind it. Once you have a hole, pull this out, pull down on that hard plastic part, and then put the hard plastic part into the sharps container. Take your tube of well-mixed blood, and behind your shield, uncap your specimen. And then remember, hold your tube horizontally. This right here is going to act as your capillary tube. You're going to fill this tube with 20 microliters of blood, and it will fill automatically. There's sort of a fill line at the end where it starts to seep into the upper assembly. And so it will fill to that point, and it will not fill any longer. So remember that when you fill your capillary tubes, you want to have both of these tubes pretty much horizontal. So as you leave your tube in here, you'll notice that it will fill, but then it will just stop filling when it has hit 20 microliters. Recap your specimen. Make sure your cap is on there good and tight. And then take a piece of gauze, and you want to just gently wipe the outside of that capillary tube. Be careful not to touch the end, because if you touch the end, you will suck some of the specimen back out again, and then you will have an inaccurate specimen. If you do what I just did and you pull your capillary tube out, all you need to do with steady hands, there we go, is just shove it right back in again. They are a little bit loose in these assemblies, but you can just shove it back in and it won't do any harm to your procedure. Now this is, I think, the trickiest part. So now we need to take our specimen from our capillary tube and we need to transfer it into our reservoir. The way that we want to do this is by gently squeezing the sides of our reservoir together, one finger over the top of the capillary tube, and then take it and insert it all the way in. Let out the sides of the reservoir, and then let your finger off of the top of your capillary tube. So if you look in here now, you should be able to see that the specimen is pretty much all inside my reservoir, and if I pull my capillary tube out, I've just got some sort of like residual stuff that's left in it. But I need to get this residual stuff out, right? I don't want to leave this in here, because then I'm going to also have an inaccurate specimen, because if this is a higher blood concentration than this, most of my specimen's in here and not in my reservoir, so I'm going to end up with a falsely low count. So the way that I want to do this is by, again, doing the same thing. I want to squeeze the reservoir together, finger over the top of the capillary tube, seat the assembly again, let the reservoir go, and then let my specimen go. Now again, I'm getting better, right? I'm rinsing more and more out every time that I do this. Oops. So out, let that go out, and we're getting a little bit clearer every time, so that's good. Once this looks pretty clear, So once you've done this probably 3, maybe 4 times, and it looks pretty clear coming out of here, then you probably are pretty well mixed. You can also leave your reservoir in here and sort of pipette up and down very, very gently to get them mixed, but don't do what I just did and squirt it out the top. If you do squirt out the top, it's okay. You'll be behind your shields anyway, but make sure that you bleach down your shields and your stations after. So once your specimen is well mixed like this, you're going to put your name or your initials and the patient number that you put together on the side of your tube, and then you're going to put it on the rocker and let it sit for 10 minutes. This is to ensure that all of your cells get mixed with all of the diluent to allow time for lysis and to give yourself an adequate specimen to be able to count. Once your 10 minutes are up, then you are going to grab one of these disposable hemocytometers that I'm trying out this year. So the disposable hemocytometers are nice because you don't have to worry about cleaning them before you use them or after you use them. You use them and then you get to throw them away. But the not quite as friendly part about these hemocytometers is that it can be difficult to find the grid on them. So when we go over lab at the start of class, I will go through some tips to help you be able to find them, but if you're having trouble finding them, I can guarantee you that you're not going to be alone. So when you open your hemocytometer, there'll be a little tear strip at the top. You're going to open it up, take out your hemocytometer, and then this is what it's going to look like. So your hemocytometer will have 2 different sides to it, so there'll be an A side and a B side, and in each of these sides is an actual counting grid, and we're going to go to the board in a little bit and look at what that grid looks like. But when we do our counts, we are going to count both the A side and the B side, and when we load our hemocytometers, these little half moon sections that are right here, that's the loading grid. So when I take my specimen off the rocker again, right, this should be all nice and mixed together. So once I take it off, this same assembly is now going to also become my dropper. So what I'm going to do is take the capillary piece out, I'm going to flip it upside down, and then this piece of the hub right here is going to attach into the top of the reservoir bottle. And so once I have that seated in here, it now becomes a dropper. But I need to make sure that I get all of the residual air out of here, because once I start loading my hemocytometer, I don't want any air bubbles. I want nice, full, and complete drops. And you also want to give yourself a little bit of time to practice it and get used to sort of the volume and the speed at which these drops come so that you can load your hemocytometer successfully. So what I recommend is just flipping it upside down and giving it a little bit of gentle pressure, and then drop, I don't know, 3, 4 drops or so out until you're kind of used to what it's like. And then when you feel like you're ready, get a nice free falling drop, hang it right over the top of that half moon shape, and you'll be able to watch the liquid imbibe down each one of these reservoir channels. So when I do it over side B, you'll see it imbibe all the way down. If you have a space that is lighter than the rest of that channel, your hemocytometer is underfilled and you need to continue adding drops until you've filled the entire channel. I will show you what it looks like if you've flooded it and if you've overfilled it and flooded the moat. It's much harder to do that on these than it was on the old hemocytometer, so hopefully we won't have that problem. Once you've loaded your hemocytometer, take the top back out again, turn it around so it's back the way it was, and then stick it back on the rocker. Do not throw out your specimen, because if there's something wrong with your count and you need to go back and redo it, you don't want to have to go through the whole process of setting this up again before you're able to start counting your specimen. So at this point, we have our hemocytometer, it's loaded, it's ready to go. We need to give it about 5 minutes or so to let all of the white blood cells settle. So when you first load it, they're kind of like just floating around in space, and so you need to give it a few minutes for them to all settle into the same plane, so that once you have started looking at your cells, everybody's in the same field of focus and you don't have to keep going up and down all the time. So when we are in lab, I will have my hemocytometer set up to the projecting microscope, and I will show you what the grid looks like. I will show you what the white cells themselves will look like, but it's very, very important that you remember that when you're setting up your microscope, you need to turn your condensers down and you need to turn your light down. You probably are going to want your light somewhere between 5 and 7, and you're going to want your condenser halfway or more lowered. So at this point, we're going to go over to the board, and I'm going to show you just a couple of things about how to do the calculations for your white blood cell count. So bear with me as we head on over to the board. Okay, so when you put your hemocytometer up on your microscopes, this is what the grid will look like. There will obviously be more lines in this, but I'm trying to show you sort of the basic idea. So each hemocytometer is going to be a grid of 9 squares. When we do white blood cell counts, we are counting the 4 large corner squares on both side A and on side B. When we count a WBC count, we always do it on 10x. So we will not be going to 40x at any point in this procedure except to confirm that what we see is not junk, it's actually a white blood cell. However, you can also use hemocytometers to do manual red blood cell counts and also to do manual platelet counts. If you were to do a manual red blood cell count or a platelet count, you would do both of those on 40x. When you do a red blood cell count, you use the middle square out of all of the 9. And the middle square itself is divided up into a grid of 25 smaller squares. And within those 25 smaller squares, you count the 4 corners and the 1 in the very middle. So you count 5 out of those 25 smaller squares within the central square millimeter. If you do a platelet count, you actually count the entire 25 squares of that central square millimeter. We'll go over some hemocytometer worksheets as well. I'll give you some things that you can practice with them so that you can figure out how the area that you count changes based on what kind of squares you're using in your calculation. So when we do our 4 large corner squares, we're going to count them all individually. So you want to make a list of how many white blood cells you saw in each large corner square on each side of your hemocytometer. Then you're going to add them all up, get a total for side 1, get a total for side 2. Add those 2 things together, divide them by 2, and that's going to give you the mean. This mean right here is really important because this is what you're going to use in all of the rest of the calculations for how you figure out your white blood cell count. So once we have a mean, the first thing we need to do is figure out whether these 2 replicate counts, our counts from side A and side B, were acceptable. Were they close enough to each other that we know that our result is accurate? And the way that we do that is to calculate our 2SD range around that mean to ensure that those replicate results are close enough to each other that our calculated WBC count will be accurate. So the way that we figure out the 2SD range is to take the square root of the mean, and that is equal to 1 standard deviation. We're going to multiply that by 2, that's going to give us 2SD, and then we're going to take the mean, subtract that 2SD number, and add that 2SD number. So in our example here, we're going to take the square root of 18.5, which remember was the mean of side 1 and side 2. We're going to do the square root, that's 4.3, that's 1 standard deviation. Multiply it by 2, 8.6 is 2 standard deviations. So we need to take our mean and we need to figure out 2 standard deviations above that and below it. So we're going to subtract 8.6 and add 8.6. So the acceptable range for our replicate counts is 8.9 to 27.1. Now, we're not done at this point because at this point I need to go back up to what my side 1 and side 2 counts were and find out, were those within this range? If they're within that range, then I can say, okay, yes, I'm good. I know my numbers are going to be accurate. But if, for instance, side 1 had only been 7, let's say I had only counted 7 cells on side 1, 7 would be outside of this range, and so we would not be able to use these counts to calculate our WBC. So if both sides are within your replicate acceptable range, then you can go on and actually calculate your WBC. To calculate your WBC, you again need the mean of both sides, and we're going to multiply that by 1 over the depth of the hemocetometer chamber times 1 over the dilution that we used, and then 1 over the area that we counted. Now, we're lucky because one thing in this equation is always going to be the same. The depth here is always going to be 1 over 10. Always. That will never ever change no matter what kind of a count we're doing. Our dilution will change, but we know that in this procedure, our dilution was 1 to 100. Whatever kind of problem you're doing for this class, I will give you whatever the dilution is. But next semester, you guys will have to calculate your own dilutions. The area that we count is dependent on the squares that we count, but we'll go through all of that when we do the hemocetometer worksheets. In this case today, we counted a total of 4 squares, and each square is 1 square millimeter. So 1 times 4 is a total of 4. So when we plug all of this stuff into our formula, we've got our mean times 1 over 1 over 10. 1 over 10 was the depth, times 1 over 100, which was the dilution, times 1 over 4, which was our area. Now, whenever you have fractions over fractions, there's more math than I really care to think about there. But all I really need to know is that whenever I have this, I get to cross out both of my numerators and my denominator just becomes a whole number. So when we fix up this equation, it turns into 18.5 times 10 times 100 over 4. When I do that math out, I get 4.625 times 10 to the third per microliter, which is a little bit on the low side for a white blood cell count. But this is important because you should know that when you do your counts in lab, your counts on each side should be coming out somewhere in this area. They might be a little bit higher than that, and that would be good, but they should not be lower than this. So that's how you're going to calculate this stuff. You need to make sure that you can do this from soup to nuts and that you understand why you're doing it before you come to lab this week, because I can guarantee you that all of this is going to be a part of your quiz. So if you have any questions, email me and let me know, but that is it. I will see you guys in lab.